computer. Okay. All right, everybody, listen, thanks for joining. It's a small group today, but that's all right. These topics we're going to discuss are kind of a culmination of a lot of the things we've learned in the past. And this is a continuation of the cases we saw from the prior week. So let's look at case 4, all right? So we're going to travel to the South Pacific. Most of you, I don't believe, have been to South Pacific. It's not a very common tourist destination, but we're going to go to the country of American Samoa, which is geographically between, let's say, Los Angeles and Sydney, Australia. It's about 3/4 of the way from Los Angeles to Sydney, Australia, okay? So that's how far it is, and it's very isolated. It takes about 4 hours for anybody living in American Samoa to be able to reach an adequate healthcare system if they have an emergency. I'm talking a life-threatening emergency. Yes, they do have hospital there. You can go to Western Samoa, which is an hour away. But again, the lack of specialists like neurosurgeons and neurotologists are non-existent in this area. So if you have a problem, you're very, very isolated in the middle of the South Pacific Ocean. So this healthy guy, you can see him, and the Samoans, they love to tattoo themselves, okay? Ethiopian women have a tendency to tattoo themselves, as do other African women who have goiters. They think that tattooing their goiter is going to make it go away, I believe. Nega, do you have any comments on the tattoos on the women's neck in Ethiopia? Nega's not hearing me. Okay. So the thing is this young man came with 24 hours of severe headache to the clinic. And he had been seen before in the clinic because he had a perforation in a draining ear. But this time he came with headaches, all right, nausea for 3 days. He had episode of vomiting, okay, and he had no vertigo. Healthy guy. I mean, totally healthy. 24-year-old guy. He can outdo every one of us. So on otoscopy, we saw this. He had an intact drum. It was opacified with some white discoloration. Agata, what's going on this image here that we're looking at? Agata, are you there?
Yes. Under the tympanic membrane, in the epitympanum, we have some devices. I thought that maybe it is cholesteatoma.
Right. What do we call this pathology here in the epitympanum? Got it. Is this a retraction? Is it atelectasia?
No, I don't see it was a retraction or atresia. I think that there is some.
Right here. What is this?
Yes, but it is like a little bit from the blood. I don't know this one.
Let me ask you a question. Is the bone eroded here?
Yes.
The bone is gone. Okay. Oscar, what do you call this here?
It's called epitympanic disease, erosion of the scutum. Epitympanitis, we call this in Ukraine.
It's called a pars flaccida retraction pocket. Okay. Pars flaccida retraction pocket. It's a large retraction pocket. Okay. And he's got otorrhea. So here we got a guy who comes in with headaches. Do we normally get headaches, Agata, from otitis media or cholesteatoma?
No.
Okay, good. You said the right answer. So that's the key to this whole case here, is that one thing. He's got headaches and he's had nausea. You don't get headaches and nausea from ear disease unless you have a fistula or labyrinthitis or something going on intracranially. So anybody
I
with,
think,
go ahead, I got it, yes?
go on. So I think that there is a pus in the middle ear, so probably it could be even the or meningitis or some abscess,
Well, let's work
or
through
maybe
this.
yes.
Let's work through this and we'll figure it out. So here he is, headaches, nausea. What's your what is your diagnosis basically at this point, other than epitympanic retraction pocket, farce flaccida, with what looks like a cholesteatoma? Okay, so that's the diagnosis that you gave me. Okay, what kind of test do we have to do on this patient now? Jose Lovera from Paraguay. What test?
CT.
Agata wants to do a CT scan. Okay, let's say you only have a CT scan, because remember, this guy lives in the South Pacific. He doesn't have PET scans. He might not have access to MRI, but they do have a CT scan there. So do you want a CT with contrast or without contrast? Agata?
Probably with contrast.
Absolutely. You want
Because
contrast because you want to enhance as much as you can. Now, Nestor, let me ask you a question. If they had a CT and an MRI, and you could only do one test, which would you do, a CT or an MRI?
CT, 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 CT.
Nestor, you there?
Yes,
You only have the chance.
yes.
You only can do one test, a CT or an MRI. Okay, which are you going to select? You can't do both.
I will choose the CT with a contrast.
Okay, you're not going to do an MRI. Okay,
If I had to choose
that's fine.
only one, yeah, I would do only the CT.
Okay.
It would give me information about the bony parts, and with the contrast, I could have some information about some soft tissue, and maybe if I have an abscess, or maybe it could be also a meningiocele in the
Okay.
middle ear.
Okay. Let me ask you a question. This is for Jose Lovera. Okay. Jose, let me ask you a question. Are you there? Lovera. Lovera, where are you? He's not listening, but that's all right. Okay. Let me see here. Alex, you there? No one wants to talk. Okay, here's the bottom line. Because the fact that this guy has headaches, I would do an MRI. I'm not worried about, I don't really care about the bony margins of the ear. Okay. What I care about is, has anything gone from the ear to the brain? Okay. I can operate on this guy without a CT scan. But if he's got something that I'm not picking up on CT scan, even with contrast, I would be reluctant to do a CT scan as the first test. That's just my approach. Okay. I want to know, because he's got these bad headaches. And yes, if we use contrast on a CT scan, we will know a lot more. So in American Samoa, they only have a CT scan, and we did a CT scan with contrast. So Oscar, tell me what you're seeing. You only have one image. The machine broke. The machine broke after shooting this one image. Okay. What do you see on this axial view?
On the axial view, I can see that there is a soft tissue mass on the right side, and also the contracted mastoid air cells, and it looks like the dehiscence between the at the area of the middle fossa,
Okay,
the
well,
anterior part.
I can't tell whether or not there's a dehiscence in the middle fossa, but I can tell you one thing. There's a smooth, soft tissue mass consistent with brain, okay, coloration, okay, smooth
Edges.
mass, okay, which means that most likely it's going to be a cholesteatoma. The rest of the air cells here are sclerotic on this right side. And remember, he's draining from the right side. The left side, we have a better air cell complex, and I don't see any disease. So let's go to this side here, okay? All right. Agata, what do you see on the contrast image on the axial view?
I see the abscess in the middle fossa.
Okay, so you see a temporal lobe abscess, okay? All right, so there's a couple things that are important. Indeed, he has an abscess with a nice enhancing ring around it in the temporal lobe, and disease that goes from the middle ear through the tegmen will go into the temporal lobe. Temporal lobe abscesses are much more common than cerebellar abscesses. Disease that goes from perisynodal, or in other words, if you have a cholesteatoma that's filling the whole middle ear, it can either go through the tegmen or it can go retrosigmoid, which is behind the sigmoid, into the cerebellum. Patients who have abscesses of the cerebellum have much more different pathology. They're going to have ataxia, much more nausea, vomiting, because you're dealing with the cerebellum, which is one of the significant organs of balance, okay? The temporal lobe, on the other hand, can be a very silent, you can have a silent presentation other than headaches and some nausea and vomit, okay? So he has a large abscess in the temporal lobe on the left side, okay? So the question is, what tests do you want to do further? If you could do any test in the world, okay, and you live in London and you're at the main hospital there, what tests would you do after this? Nega, what would you do after this? If you could do any test in the world? Can't hear you, Nega. Hold on, let me unmute you. Nega, we need to take your microphone on. Okay, good. Yeah, Nega, what would you do next if you could do any test?
I do blood test also, because if it is abscess, we will have elevated white blood cells.
So you want to do an MRI? Okay, I think that's more than appropriate. Because what's going to happen is, as this abscess gets larger, it's going to push all the brain in the right hemisphere across the midline, and you're going to get collapse of the ventricles, okay?
Yeah.
And potentially you get herniation of the brain, okay? As you get expansile, as this mass of abscess expands, it also can infarct the brain because it's cutting off the microvascular blood supply. So the bottom line here is, yeah, we're going to get an MRI, okay? Do we get a consultation? And the next question is, what are our treatment options? Okay. So Oscar, are we going to get a consultation? And if so, what kind of consultation are we going to get?
It is good to involve a neurosurgeon into the treatment of this patient, if it's possible, actually.
Absolutely. Absolutely. You need a neurosurgeon, okay, to be able to consult with you, because this is beyond our realm of expertise, okay? And the treatment options for anybody with a brain abscess will be based upon a couple things. Obviously, it's going to be based upon how long the abscess has been there, whether or not the capsule is a mature capsule or not. It's going to be based upon whether or not there's any midline shift. It's going to be based upon the neurologic exam and what are the, is the patient starting to have other cranial nerve involvements? And most importantly is, how is the patient doing? Again, this gentleman came to the emergency room at that local hospital in American Samoa with nothing more than headaches and some nausea and vomiting, okay? And a diagnosed abscess, okay? He had a slight leukocytosis, not much of a fever, and his mental status was completely normal, okay? So based upon that, based upon what I just told you, do you operate on this abscess? Do you treat him with antibiotics? Or do you watch?
Yeah.
So that's the question. What are you going to do here? You're going to watch him? You're going to treat him with, you're going to watch him and treat him with antibiotics, or are you going to operate on him? Lovera, you there? Nestor, you there?
Yeah.
Yes, yes.
Yes.
Or what are you going to do with this guy?
I will.
What?
We watch him
Okay.
and also give him some IV antibiotics.
Okay. And does anybody disagree with them? Does anybody think you need to operate immediately on this patient?
I think that. Yeah,
What do you think, Agata? Come on, Agata, give us your opinion.
R ورقة كهون R إيه كله كابيتال دي
Feely,
R كابيتال كأخر
Browner, Feely,
هنشع
Feely.
Yes Richard
How you doing? Tell me something. Are you going to operate on this patient, or are you going to watch him and treat him with IV antibiotics?
I'm sorry I didn't
You don't know the case.
follow up. My connection was lost.
Okay, your connection's slow from Ethiopia. Okay. All right.
Yeah.
Nestor was correct. We're going to treat.
Richard.
Hello? Yeah.
Okay.
Hello.
Yeah, Nega, go ahead.
Yeah. Both, treat him with antibiotics, broad spectrum antibiotics, and surgery. If abscess, only antibiotic is not enough. We have to operate on him.
Okay. Here's the situation. The neurologic consult is critical. Okay. But more importantly is you need to start this gentleman on broad spectrum antibiotics.
Yeah.
Broad spectrum antibiotics immediately. And maybe a little mannitol to decrease intracranial pressure. Okay. And some dexamethasone. You need to get this patient started. These abscesses that are small, that don't have a mature capsule, you can treat them conservatively, but you got to treat them in conjunction with the neurosurgeon. And what you need to do is every 24 hours, you need to do a repeat CT scan to make sure that the abscess is shrinking in size. Okay. If you're under this, okay. Second of all, this gentleman should have been shipped to Hawaii or New Zealand immediately, but they didn't do that. Okay. So if you see that the abscess is expanding and not responding to broad spectrum antibiotics, you need to drill, you need to operate, you need to drain the abscess. Okay, absolutely. What happens with these abscesses, if they continue to grow, not only do they do a midline shift, possible herniation of the brainstem, but they'll rupture. And when these rupture, your patient's essentially dead. Your patient's going to die from a ruptured brain abscess, okay? So we start them on IV antibiotics, and let's look and see what happened to this guy, okay? So there were some general surgeons that were kind of, overstepping their bounds, as one might say. And what they did is they decided to treat him. The general surgeons decided this patient needs to be operated on. Okay. So this is maybe some of you have heard the story before, but we're looking at the X-ray, the CT of this patient after treatment. And there's numerous things that are really important here. Okay. I've seen this a number of times. Okay. But we're going to ask Oscar to help us out here a little. Okay. Oscar, tell us what's going on. What do you see here? This is like playing a detective. You know that the patient had something done, and you know what the CT looked at. This was before surgery, temporal lobe abscess. Okay. Here's the cortex of the skull. Here's the midline. I don't see any shift in the midline. Okay. And now let's go here to the post-op CT. Tell me what you see. Do we have a midline shift or do we not have a midline shift?
I can see a midline shift because at the posterior end, you can see that the left hemisphere, the right hemisphere is shifted to the left side. Also, the position of the ventricles are displaced on the right side, and looks like there's still a capsule of that abscess, but the surrounding soft tissue around is more hypodense. Maybe was it surgery on this patient?
This patient had surgery. Okay. So the abscess is still here. There's a shift to the midline with collapse of the lateral ventricle. You can see
there's hypodense soft tissue, hypodense gray color on the left side to the abscess, and it looks
wait. Where's that? Here or here?
No, here. They're more lateral to the abscess. Here where you just pointed.
This right here?
The hypodense, maybe it's also a necrosis of the brain. And up to the abscess looks like the hemorrhage because it's more hyperdense.
Where, this here?
Mm-hmm.
Okay. Okay, and what's this right here?
And this looks like not completed craniotomy. Because it still looks like, I don't know. Oh, maybe, I don't know. Maybe they use some like sort of like a very large needle with a large diameter, and what they tried is to
called the burr hole in the skull. It's where you drill a hole, stick a needle
make a puncture,
and you go through the dura into the brain, and you try to aspirate the abscess. Okay. Just 1 second. Aziz, did you have a question?
No, I was thinking that there's a brain herniation as well as what looks like was there's a blood and multiple small abscesses in the brain. So I think the abscess was ruptured and there was a multiple focal.
Okay, the abscess was never touched, but there was hemorrhage intracranial. He bled. This is all blood intracranial. The abscess is right here.
Okay.
This is where they made the burr hole. The burr hole was way too far anterior. The burr hole should have been here, and it was created there. Okay. So unfortunately, what happened to this gentleman, he died. This 24-year-old gentleman, had they been patient enough, probably would be alive today because he was stable. He could have been treated with IV antibiotics conservatively, and most likely he would have gotten better. Had he not gotten better, that would have just been the consequences. Also, immediately upon diagnosis, he should have been airlifted or scheduled to be airlifted to either Hawaii or Auckland, New Zealand, okay? So this would have been the treatment of choice for neurosurgical intervention, would have been to put a halo, a stereotactic frame around him, and an image-guided needle aspiration of the abscess, okay? And again, you want to reduce the intracranial pressure so this thing doesn't expand, okay? And unfortunately, I guess the take home on this case for all of us is that, number one, when patients have headaches, nausea, and vomiting, don't think fistula, think brain abscess before you think fistula, okay? Or viral labyrinthitis, or bacterial labyrinthitis, okay? Number one, okay? Number two, if you can get any test possible with patients who are having headaches, get an MRI first, because you know what? If you've ruled out an intracranial problem and you know the patient's got pus draining from their ear and you can see the cholesteatoma, you can operate on that patient without the CT, okay? You can't, operating on a patient just based on the CT without knowing what's going on intracranially. When a patient has severe headaches, you're going to miss the pathology, the intracranial pathology. Really, really important, okay? And obviously, neurosurgical consult, okay? I don't recommend, unless you're living in Timbuktu where there's not any access to care, I'm not really a proponent. I'm not really a proponent for, sticking a needle through somebody's brain, because as you can see, you can kill them when you're trying to help them, okay? So I hope that, sheds some light. And here's a picture of what the brain abscess will do. Here's the midline shift, okay? You can see the abscess here. You can see edema and necrosis of the brain around it, okay? So it's not a very good thing to experience, especially when you have to do, confirm it on autopsy. Okay, does anybody have any questions about that case? If not, we'll move on to case number five. Yeah, go ahead, Naga.
Yeah.
Uh-huh.
How about, is there a place for tuberculosis?
Is there what for tuberculosis? What?
Yeah.
Is it possible to have tuberculosis at tuberculosis?
Yeah, exactly. Yeah. Mm.
I don't see, absolutely. I mean, tuberculosis is a bacteria. Okay. Fortunately, it's rare. I've only seen one case of otologic tuberculosis in my life, but any bacteria that's in the middle ear can go through the veins that are in the ear are valveless veins, just like in the cribriform plate. They're one-way valves so that the blood can go backwards. And that's what causes this to happen in the tegment. This is an epitympanic cholesteatoma. The disease was in the epitympanum and it went through the tegment, okay, into the brain. So absolutely, this could be a tubercular abscess, okay? But more likely, because tuberculosis in more of the developing countries is not as common as, standard, staph, strep, you'd want to obviously get a culture, but you got to cover for everything. Okay. All right. Case number 5.
I have also a question. Should we make a drainage of this ear? Just give an antibiotic and just let the pus in the ear let out?
Okay, so your question, which is a very good question, is when do you treat the ear in comparison to the brain abscess? Okay. All right, because we need to treat the source, okay? And the answer to your question is as follows. First of all, you're not going to take a patient with a brain abscess and go do a mastoid on them, unless the neurosurgeon is going to go drain the brain abscess and the patient's stable. Okay, patient goes to OR in a stable condition, neurosurgeon drains the abscess and he feels comfortable, okay? You can go ahead, okay, and quickly do a cortical mastoidectomy just to drain the source of the abscess. And in this case, most likely it's going to be a canal wall down abscess, okay? Or canal wall down procedure, okay? Because he's, you know, you want to get in and you want to get out as quickly as possible, all right? To go and drain the brain abscess, to do a mastoidectomy, leaving the brain abscess there, you're not going to die from not doing a mastoidectomy. You're going to die from the abscess in the brain. Okay, so everything you do has got to be coordinated with the neurosurgeon. Okay, if he goes in and the patient's stable, you can go do the mastoid. If not, let him drain that brain abscess if he feels it's necessary, especially in the unstable patient. Let him get treated with antibiotics, and you can go do the mastoidectomy and treatment of the cholesteatoma at a more, you know, at a time when the patient's more stable. Okay, all right.
Thank you.
Let's go on to case number 5. Case number 5. All right. Everybody, just want to let you know we have Dr. O today. O, he's joining us from Fiji. Fiji is in the South Pacific. Okay. It's not far from American Samoa. Dr. O, thank you for joining us. Nice to meet you. Okay. Okay, we had a good case. We'll show it to you another time, Dr. O. So we're going to go on to case number 5. Some of you in Paraguay might remember this patient. He was a 26-year-old male, lives in Asuncion, and he was walking down the street. He got hit from behind by a motorcycle. Went to the emergency room, was seen by ENT. He complained of some mild dizziness, no vomiting. He had clear fluid coming out of his right ear, okay? Clear fluid. So my question now, okay, Dr. O, since you're new, we like to challenge our friends from the South Pacific. Tell us something. What is clear fluid in somebody who has head trauma that comes out of the ear? What is the clear otorrhea? What do you think it is? Dr. O, you hear me?
Yeah, I didn't hear the case 5. I think it's possibly after the trauma, it's possibly the CSF or Torea. So I think they need to.
Yeah, what is the clear otorrhea coming out of his ear? Is it water? Is it, you know, what is it? Where's the fluid coming from that's coming out of his ear?
Is it possibly the CSF?
It is CSF.
Yeah.
It's CSF. It's exactly. So this is CSF, which tells you he has ruptured at least his tegmen, okay, because he's got clear otorrhea, okay. So what do you do in a case where you got a patient who's neurologically intact, okay, you've done an MRI, no intracranial hemorrhage, okay, you've done a CT, and you see a fracture of the temporal bone, and he's got otorrhea, okay? How do you treat this type of patient? What's the next thing you do? Anybody can talk. Dr. O, please go ahead. Yes.
Yeah, generally it's a conservative treatment. If there are no symptom, no meningitis symptom, just a conservative treatment with the preventive antibiotics, the penetrated the BBB. Yeah, but if there are a lot of the pulsating the CSF, we can do the packing with the gel form or Surgicel inside of the middle ear cavity, or if there are the continuous this one, I think we can do just open the mastoidectomy and the fracture site. We can using some fat packing with the fracture site with Burash. We can do that like this. Also, we can use the medicine for the reduce the pressure of the cranial cavity.
Okay, so you're
sorry to interrupt.
You're ahead of the game, Dr. O. We'll get back to you. Aziz, did you have something to say?
Yeah, sorry for interruption, but I'm interested to know about the condition of his hearing as well as the facial nerve condition, and then
Okay, those are really good
I'll do
questions. And I'll add more to that. First of all, his facial nerve was functional. No problems with his facial nerve. Okay. Second of all, is his hearing was his hearing. He had a conductive loss. Okay. He had a conductive loss of 30 decibels. Okay. So here's a guy. The only complaint other than clear fluid coming out of his ear from the trauma is just the clear fluid. Okay. So what they did.
Richard,
Yeah, go ahead, Nestor.
the first thing I was going to do is treat him with antibiotic and let him rest.
Nestor, I can't hear you.
What I will propose for this patient is admit him and treat him with antibiotics and let him rest.
Okay, the treatment of antibiotics, I believe, is controversial. Okay, because what you want to see is you want to see what happens to the otorrhea with bed rest, with the head up. Okay,
Yeah.
and you'll
Yeah.
find that a lot of patients, I can't give you a statistic, but the CSFs will, the spontaneous otorrhea will stop. And if the CSF's otorrhea stops, you don't have to worry about anything at this point. Okay. If you put a patient on antibiotics prophylactically, you might mask their a potential meningitis. Okay. You're treating something that's not there yet. Okay. Second of all is if you culture the otorrhea, you're going to find bacteria because there's bacteria in the middle ear and the otorrhea is coming out of the ear canal. So you're going to find staph, definitely. Okay. So you know what I think is a good thing? Oscar, you there?
Looks like, yeah, it looks like, at least for what you're telling to us, it looks like very like a longitudinal fracture of the temporal
Well, we haven't
lobe,
gone
because
there
the
yet.
facial nerve is intact. There is no sensorineural hearing loss, and the conductive loss could be because of the displacement of the head of the incus and the incus malleus
Oscar, you're getting way
dislocation,
ahead of
or
yourself.
maybe
You're
the
getting way ahead.
hematoma of the middle ear.
So Oscar, you're going to do us a favor before you go to bed tonight, because it's already 11 o'clock in the Ukraine. Okay. Before you go to bed, you're going to send everybody on WhatsApp and you're going to answer the following question. Do you treat CSF otorrhea, traumatic CSF otorrhea patients with antibiotics? Is it recommended or do you watch and wait? Okay. So why don't you answer that for us? Because Dr. O got up early. It's like 5 in the morning in Fiji. Okay. And he's, you know, he wants to know more. Okay. So the bottom line is we'll get that answer. Okay. From Oscar. So here's our
so
otoscopy.
Prof, can I interrupt?
I'm sorry, go ahead, Aziz.
Can I interrupt? I have two similar cases like this one, and in a couple of years ago, they had a Bajaj, what's called a Bajaj accident, and in here in Somaliland, because of there are too many infectious diseases and our sterility was not that clear, so I gave them bed rest and aggressive antibiotics, and then the CSF stopped in a week, and then the patients recovered completely, and then they go away home. So I was wondering, different antibiotics in a tropical and Lausanne, is that something recommended, or just because in different parts of the world, the microbes and the condition of living and everything's different?
Exactly. And you know what? Well, let's wait to see what Oscar has to say, okay, before we
Okay.
continue
Thank you,
the
bro.
conversation. All right, so here's what happened to him. He quit draining, the CSF otorrhea stopped, and he went home a week later. This was otoscopy on him when he came back, okay, and he had stenosis of his ear canal. He had a fracture, okay, he had a fracture. You can't see anything here because there's no landmarks, okay? He stenosed his ear canal. He had exposed skin from the temporal bone fracture, okay? It healed over, it closed the ear canal. He came back, okay, for follow-up visit, and then he came back a year later, okay? All right, and here is the CT scan on the patient. This was a CT that was taken when he came in from the trauma. And you can see he's got a temporal bone fracture here. All right. Here's the facial nerve, not involved. Okay. He's got a free floating segment of bone here on the tegmen. Here's a big fracture here, another fracture here on the coronal view. On our axial view, we have a fracture here, we have a fracture here, and we have a fracture there. This could be the mastoid emissary vein, but I think we're too high up for that. Okay, so he's got multiple fractures, no involvement of the facial nerve, CSF otorrhea that stopped. Okay, so what do we do now? This guy comes back in follow-up. Do we just tell him, hey, nothing's draining, your ear canal is closed? Do we tell him there's nothing to do? Do we do a canalplasty? Do we do a mastoidectomy? Okay. I guess most important is when you have a canal that's stenosed traumatically, what are you worried about? What are you worried about that's going on behind the stenotic segment here? Remember,
I would worry if the
There's
brain tissue there.
what
you're worried about what, Nestor?
It could be brain tissue, herniated brain tissue there.
Absolutely. There could be brain tissue. What else could there be?
Trapped skin.
Skin. What does skin do behind
then he will he will have a cholesteatoma of the external auditory canal.
Absolutely. I guarantee you, every patient who has traumatic stenosis of the ear canal with squamous epithelium behind it will develop a cholesteatoma. Okay? So here's a guy, traumatic stenosis. He's got a cholesteatoma behind this ear, okay, or behind the stenotic segment. All right? He's going to need surgery, okay? He's not developed, the CSF leak stopped a long time ago, but the stenosis and the 1 year post-op waiting period, he has got a cholesteatoma, okay? So we're not gonna watch him, we're gonna operate on him. Irrespectively, that ear canal has got a cholesteatoma behind it. We're not gonna do a canalplasty, we're gonna do a mastoidectomy. So let's look here. This is his right ear. Hold on, let me just do so. Okay, this is right ear. I've elevated the palva flap. Spina Henley's here. Cortex of the mastoid. And I believe this was one of the fractures, okay? One of the fractures. There's some blood in it, only from the blood of the current surgery, all right? So let's watch and see what we see on the video. I'm lifting up the, I just got in here to, I'm lifting up the conchomeatal flap, and all of a sudden, you see that? This stuff right here is white and cheesy, right behind the spina Henley. It's cholesteatoma. Cholesteatoma, and here is one of our fractures. So at this point, I got a stenotic ear canal, I've got a cholesteatoma, okay? I don't know the extent of it, okay? And I know I've had a previous CSF leak with a large fragment of the tegmen, which was floating freely. So I'm gonna just do a little more exploration here. And again, here's your cholesteatoma behind, this happened in a year, okay, behind the stenotic canal. And things just looked a little weird up here. It was like glistening gray. So I decided to go and do a cortical mastoidectomy to get a better view of what's going on, okay, to see if there was any further extension of the disease, all right? So here I am, following the tegment, the temporal line. I'm just gonna open up the mastoid and get an assessment as to what's going on, which will eventually determine the extent of my surgery, okay? So I've decided I'm going to take the canal wall down because I see more glistening stuff here and the glistening stuff there, which was, we'll talk about in a minute. So we're going to take all this down. We know we have a free floating segment. Our goal here in this patient is to make a safe ear. A cholesteatoma in a patient who has had previous CSF otorrhea is a patient who is a setup for meningitis. So here we're going really slowly, and you can see this like jelly, this gray jelly here. And there's a little CSF that just popped out of there. Here's more cholesteatoma. Here we go again. This is the middle ear cavity down here. This is part of the fragment of the fracture. I'm taking some bone fractures, and see how this stuff is like paper thin gray jelly. Here's part of the fracture there. So what's going on here is the following. This patient has essentially necrosed all of his dura in this section. There is no dura. This gray matter that's really jelly-like are the arachnoid granulations, okay? We rarely see, I mean, we don't see arachnoid granulations unless we're neurosurgeons. Arachnoid granulations produce CSF. So we have got, over this 1 year period of watching him and him coming back, we've noted that he lost all of the dura, exposed arachnoid granulations, and there's been some necrosis of some of the bone. Because there was absence of bone here and here, I removed this fragment and I removed the rest of the cholesteatoma. So, in this,
Do you still have CSF leak?
do what?
Do you still see CSF?
No, do I have CSF leak?
Yeah.
Is that the question?
Yeah.
There was a small amount of CSF leak, yes. Okay, but here's the situation. This patient's not reconstructible. This defect, okay, was essentially 5 centimeters in length. There's no floor to the middle fossa. There's no roof to the middle ear or the mastoid. We now have the obligation to make this ear safe, and we have to proceed by doing the following. We need to close this ear off, prevent any further cholesteatoma, and most importantly, prevent any CSF leak. So we have to drill out the rest of the squamous epithelium from the anterior canal wall here. We have to we have to block off the eustachian tube, okay? And we need to obliterate this whole cavity with fat. It's called a blind sac closure. So I've already answered these 2 questions for you. How do we close it? And what do we do post-operatively to follow the patient? We'll get back to this question in just a second. So for those of you who do not or are not familiar with the term blind sac closure means you are closing off the ear canal. Okay, and the way you do that is you amputate the ear canal, you remove some of the cartilage from this area, you evert the skin, you sew it closed, and you take the palva flap and you lay it over for a second layer of closure. Now, when you look at the ear canal with an otoscope, you just see a blind sac. Okay? In the mastoid cavity in the middle ear, now you have obliterated or filled the mastoid cavity with fat from the abdomen. Okay, you make an incision like an inguinal hernia incision, you harvest fat, and you pack the mastoid cavity. Once you've removed all of the skin, once you've plugged the eustachian tube, okay, there's only 2 ways of getting meningitis in a patient like this. One would be if you left the ear canal open and bacteria came in through the ear canal. Number 2 is if it traveled from the nasopharynx up the eustachian tube into the middle ear cavity. So you have to block the eustachian tube. That is done by either curetting the eustachian tube and packing it with fascia, okay? And then putting your fat in the mastoid cavity to obliterate it. So you've got to, this whole procedure here is to prevent him from getting meningitis in the future. Yes, it would be nice to reconstruct his hearing, but that's not what we're gonna do. If he has an adequate ear bone, if he has only an ear bone gap with no sensory neural hearing loss, the patient could wear a Baha hearing aid, okay? But our goal here is to prevent him from getting meningitis. So now let's go back to this question. We've operated on him. We removed the cholesteatoma. We've obliterated the mastoid cavity, and we've done a blind sac closure. What do we do 1 year from now for this patient in follow-up? Okay, what kind of test, what do we want to watch for in 1 year? What are we concerned about?
MRI.
What are we concerned about? I didn't ask you what
Eh,
we're doing.
Maybe we
if
left
you-
some.
I can't hear two people.
Maybe we left some.
Residual cholesteatoma.
Absolutely. We are worried that this patient, no matter how good a surgeon you are, patients get recurrent cholesteatoma. So we're worried about recurrent cholesteatoma. What special test are we going to do 1 year from now? Are we going to open him up, take the fat out, and see if there's cholesteatoma? Or are we going to image him with a special test to see if there's a possibility there's cholesteatoma? Nestor, what were we
can
going
do
to do?
the
I would like to do an MRI with the diffusion test.
Absolutely. You have to do a DWI, diffusion weighted MRI, which will specifically look at whether or not there's residual cholesteatoma in the mastoid cavity or in the mastoid area, okay, where the disease was originally. All right, there's special sequencing of MRI, and you have to specifically request from the radiologist that they do the diffuse weighted imaging, okay? There's a guy in, where is it, Amsterdam? No, he's not in Amsterdam. He's in, no, maybe Luxembourg. I don't know. There's a guy who just does mastoid cavity obliterations on all of his patients. And the thing he does, he scans everybody. He's taking mastoid cavities that are full of cholesteatoma, removing the disease and putting bone pate and reconstructing and rebuilding the mastoid cavity so that he can create small cavity mastoidectomies, okay? He doesn't want to go back and clean mastoid bowls. But he has the liberty, okay, of doing diffuse weighted imaging on all of his patients to see if there's residual disease. Again, if there's residual disease, it's going to be under the bone that's reformed when you put the bone pate in. If you leave a large cavity open, you'll be able to do otoscopy under the microscope and see residual disease. But when you have reconstructed with bone pate, you cannot see if there's cholesteatoma. That's why the diffuse weighted imaging is the test of choice, okay, requested upon the radiologist in a patient who's had known cholesteatoma, but you cannot see it because you've reconstructed the patient in such a way that direct visualization is impossible, okay? All righty, that's that for that case. And blind sac closure. You can see this blind sac closure technique is not a difficult technique. It just requires a few moves that are different from what you've done in the past. Again, so that's that case. You know, it's already 1 hour. I have multiple cases to do. If you guys have time, I'll continue on with the third case. If not, we can postpone this for another week. No complaints, let's go. Especially Dr. O, he got up and, you know, Where do you live, in Suva or Nadi? Nadi? Nadi or Suva? I can't hear you.
I'm in Suva.
You live in Suva.
I can
Okay,
hear.
I've been to Suva. Okay, I've been to Suva a long time ago. Okay, all right. This is a really nice lady, 48-year-old Ecuadorian lady. And she came in with progressive facial weakness on the left side. Been going on for about a year. Normal hearing, no ring, no tinnitus, no vertigo. She had no other cranial nerve palsies, okay? But isolated facial nerve weakness, okay? And here you can see in her standard photo, and here she is smiling. And you can see how she's got the weakness here on the left side, okay? So in a patient like this, what is your, there's a host of things that could be, causing this. First of all is it's been going on a year. So where's Agata? Is she still here? Agata's here. Okay.
Yes, I am.
Okay, this is going to be for you, and it's going to be for Browner from Necker. Okay, so here's the question. Is this a malignant pathology or is it a benign pathology?
It takes 1 year.
It's been there a year, progressively getting worse.
And worst, it's going worst. So
The
it
facial
could be
weakness is
rather
getting worse.
malignant.
Yes.
Mhm.
Is it benign or malignant? You have one second.
Malignant.
It's what?
Malignant.
You're going to say, okay, Browner, you there? Feely,
Yeah.
you got bad connection today. Okay, Feely, is this benign or malignant? Feely. She's having communication problems from northern Ethiopia. Okay, Nega, you there?
Yeah, I'm here, Richard.
Yeah, better internet.
It's not. It's by.
Hello.
Hello.
Nega, is this
Richard?
benign or malignant?
It's a benign, maybe it's a glomus tumor. Glomus.
Okay, Feely, we can't hear you. Don't worry about it.
For 1 year in it.
Okay.
No,
so-
Richard.
Yeah, hold on, Nega.
It's
Just
a benign tumor. It's a glomus tumor.
okay, Nega. It's okay. So the answer to the question, it is most likely benign because it's been there a year. If it was malignant, like metastated breast cancer causing a facial nerve paralysis, she'd probably be dead by now. Okay, number one. Number two is Nega's jumping the gun because he says it's a glomus tumor. Okay, because it's not a glomus tumor. I'll tell you that, first of all. But glomus tumors can present this way. You got to examine the patient. You got to examine the patient, okay? Otoscopy is completely normal. Her normal canal, normal drum.
Okay.
No other cranial nerves involved.
Mm-hmm.
Normal hearing.
Okay.
Normal hearing,
Uh-huh.
no vertigo. So what's the chance that she's going to have an acoustic tumor?
Okay.
The chances are small. Acoustic tumors that are large, that are getting progressively larger because symptomatically she's getting progressively worse, you're going to have some kind of pathology. You're going to have some kind of hearing loss, okay? Ringing in the ear. You're going to have, dizziness if it's compressing the cerebellum, okay? If it's compressing the brainstem, okay? So, but she's got nothing. She's only got a facial nerve paralysis, okay? So what
Richard,
Nestor, go ahead.
it could be the Hisen facial nerve, and even if you have an acute otitis media, you could have a facial paralysis.
Absolutely.
Or if you have, yeah, or a chronic or otitis media, you will have facial paralysis if your facial nerve is dehiscent.
Absolutely. But the problem is, Nestor, she's
But
not had any ear disease, no ear disease. She's not dizzy. She's got no headaches. She's got no vertigo. She's got no tinnitus. Okay? And it's
I
been
think
going on for 1 year and getting progressively worse. Okay, Aziz, go ahead. What's your question?
no, I'm just adding a comment. So what makes it a little quite weird was that it was progressive for a year. So maybe something is getting infiltrated, but I couldn't see.
Okay, it's
I couldn't
progressive.
see. So
She lost her complete
yeah,
nerve.
yeah.
She went paralyzed.
Maybe this is
She went
schwannoma
paralyzed
of the
on the
facial
left
nerve.
side. And she started to even have it on the right side. Okay, I'll help you guys out because the next case is, here's her CT scan. This is the right ear. This is the left ear. Anybody know the diagnosis? Because this is the diagnosis. This is the whole case here.
There's some bony stiffening. So maybe there's some bone pathology over there.
So is there a bone disease or what?
Is it the neurofibromatosis type 2?
Neurofibromatosis type 2? No.
It's a bony, it's a Paget disease.
Is it what?
Paget disease.
You're close, Nestor. This disease fits in a category called osteodystrophies. Okay? Osteodystrophies. And there's numerous different pathologies. Osteogenesis imperfecta is probably the one you'll see more than any of them. Those are patients who have blue sclera, have you seen, and conductive hearing loss. And they present like a patient with otosclerosis because they'll have fixation of the stapes. So she developed not only left-sided paralysis, but she developed right-sided paralysis. And what was happening is this is called fibrous dysplasia.
Cortical.
Okay. And what she was getting was fibrous dysplasia of the internal auditory canal on both sides, and it was compressing her facial nerve. Here you can see the thickened cortical bone. This fibrous dysplasia can affect all bones of the body. Facial bones, temporal bone, long bones, any bone of the body. And what happened is she started, compressing the facial nerve. So what can you do? Do you do a middle fossa and decompress this? The answer is beyond difficult. Fibrous dysplasia, when you operated on it, is like taking a sponge full of blood and trying to drill the septations out of the air cells. It's extremely difficult. The bone is soft and bleeds, okay? And you're probably paralyzed her irrespectively. She's already getting paralyzed. So, if you can find a way to do this without bleeding, you could probably try to decompress her. But I've talked to people who have, neurotologists, and they wouldn't approach it. Here you go. Here's another image. This is not the same lady, but you can see significant fibrous dysplasia on the left side here, encapsulating the whole temporal bone. The only thing normal is the cochlea and the malleus. Everything here on the left side is fibrous dysplasia. Here on the right side of another patient, fibrous dysplasia here of this large area. I could show you X-ray over X-ray of X-ray of this fibrous dysplasia. And here's what we see Neg has probably seen more of this than anybody, that you'll see that patients who have facial bone fibrous dysplasia will show significant facial asymmetry. Look at the eye of this young girl on the right compared to the left. Okay. Same thing here. The orbital structure has been developed in a significantly abnormal manner compared to the right side. You can see here, this gentleman, significant maxillary deformities and mandibular deformities. Intraorally, you can find large abnormalities of the hard palate, the nasal bone. So when we talk about these osteodystrophies, you know, you're going to have a rheumatologist get involved with you. But, you know, otosclerosis is an osteodystrophy. You know, we know it only affects the you know, the oval window. It can affect the cortical, it can affect the oval window and the cochlea. And on CT, we see, if we can see the disease of the foot plate, we will. Otherwise, if it's involving the cochlea, we'll have a mixed, if not a pure, a mixed hearing loss, and we can see demineralization of the cochlea. Osteogenesis imperfecta, okay, osteogenesis imperfecta is in younger children, younger age group. It gives you that blue sclera. And then the patients will also have many times a shorter stature and history of fractures. And you can see on CT in patients with osteogenesis imperfecta, the scutum, the cochlea, and the stapes can all be involved. In patients with Paget's disease, more effective, what we see classically is that it involves just the calvarium. It doesn't affect the inner ear ossicle or the middle ear ossicles. Patients have deformities of the long bones and fractures. Osteopetrosis, again, I've seen patients with Paget's, osteogenesis imperfecta, otosclerosis, and fibrous dysplasia. Osteopetrosis is where the long bones become nothing but solid. There's no pneumatization of the mastoid on CT scan. They can have fractures, and because the long bones lose their inner structures, the patients will have anemia because you're not producing. The long bones are contributing to the production of red blood cells. The fibrous dysplasia, as we saw in this lady, all bones can present with it. Painful fractures can also occur, and we get, as we saw, narrowing of the internal auditory canal. Last of all would be otosyphilis. I've never seen it, so there's really not much I can say about it. Okay. So anyway, that is the gist of today's lecture. I don't really have much more to talk about on these cases. I think they're all interesting because you should be able to know from what you already have in your brain, in your database, what is normal and abnormal. You know, this lady, because she had a year of progressive facial weakness, we know it's going to have to be benign. Okay, the fact that she didn't have any hearing loss or vertigo really it makes you kind of shine away from an acoustic neuroma, but maybe she had a meningioma. Okay, the real answer to it is imaging. Okay, so I hope all of these cases were helpful to you today. We're going to have some more case studies, roundtable discussions in the near future. I think Dr. Monfred from George Washington University will be giving us some roundtable discussions. We have Dr. some of you from Paraguay might know him, Jonathan, from Johns Hopkins, who's going to talk to us about the advances in thyroid surgery. They're doing endoscopic sinus, endoscopic, excuse me, endoscopic thyroidectomy, labial. We got some lectures on microtia coming up. Does anybody have any questions? If not, I'll wish you all a good weekend, and I'll send you some information on WhatsApp platform this weekend as to what the next lectures will be next week. Okay. Dr. O, do you have any questions for us?
So much as a Professor.
Do what?
Thank you so much, Prof. Really appreciate it.
Thank you, Richard, for
You're welcome.
such a
Okay, Dr. O, any questions for us?
No, I don't have any question, but I think this is very useful for the Fiji. I think that we will do participate the Saturday morning. I think that this is could be the useful tool for the learning and the teaching in the Fiji ENT registrars and the general physician.
No, we're glad to help you. Usually we do this on Tuesdays, but it changes. Okay, it's Saturday morning.
Yeah.
It's Saturday morning in Fiji, huh?
Yeah, now Saturday morning. Today is a Fiji day.
Yeah, it's Friday morning in Seattle, and it's nighttime in Europe. So I'll send an update. I think let me just tell you guys, since you're on, I'll tell you what the next lecture is. Hold on a second.
Thank you so much. And I'll be back next week. I will keep in touch with you, then Richard and Misha. Thank you so much.
Okay. I'll send everybody a WhatsApp this weekend with regards to what we're dealing with in terms of our lecture for next week. So have a good weekend, everybody.
We are happily waiting the YouTube channel.
Okay, everybody. Bye, Philly.
Have a good day.
Agata left.
Bye.
Okay, bye, everybody.